Good morning, everyone. I'm Emily Akhtarzandi, Managing Director of AtlanticLIVE, and I'm delighted to welcome you to our event this morning, the Equity of Health. Today, we'll examine what can be done to expand access and reduce costs throughout the healthcare system. We need no reminder that the U.S. spends more on healthcare than any other country, and yet we are far from the healthiest country. Too much is spent on the sickest and most complicated medical cases, and yet for many Americans, access to care is lacking. The Atlantic recently explored this issue in our pages with an in-depth look at health equity in Baltimore, where we explored how the community is looking for solutions from housing to food to healthcare. And so today, we'll continue to explore how all stakeholders can work to expand access, reduce cost, and increase outcomes. Before we begin, I'd like to take a moment to thank our underwriter, United Healthcare, for making this conversation possible. And a few housekeeping notes. Please silence your cell phones, but keep them out to follow the conversation on Twitter. Our handle is @AtlanticLIVE, and we're using the hashtag AtlanticHealthEquity. And we'll have time to take your questions here in the room throughout the morning after the panels. So first up, for a conversation about the government's role in health equity, please welcome to the stage Seema Verma, the administrator of the Centers for Medicare and Medicaid Services. And here to lead the conversation, please welcome the Atlantic's Washington editor-at-large, Steve Clemons. Steve, the floor is yours.
Good morning, everyone, and welcome to the Atlantic Festival. Thank you so much for joining us this morning. I was doing my preparation last night, and I ran across your budget figures, and if they are correct, you're the trillion-dollar woman. How many, so $1 trillion budget, if you're not in kind of defense, is huge. Does that get you more respect in the among the Trump crowd that you have a $1 trillion budget?
Well, I wish it was my shopping budget,
yeah.
But it's not. It is. It's one of the largest budgets, and we serve over 130 million beneficiaries between Medicare, Medicaid, and the exchanges. So I always like to say what happens at CMS sort of impacts the entire health industry because we are the nation's largest insurer.
Right. It's hard for me to think, in my role at the Atlantic and my privilege of going around the country, of a more important set of issues than cost and access in healthcare, and I know that that's very much on your mind. What are the things that you're bringing to that you think are making the overall system less wobbly and trying to address the issues of rising costs of healthcare and the concern people have about access?
Well, I think you brought up the main point, or what I would say is the most significant issue in healthcare is the cost of healthcare. When I think about what I wake up in the morning and think about when I go to bed at night, this is what I'm thinking about. Our healthcare costs are soaring. By 2026, it's projected to be 1 in every $5 will be spent on healthcare. And so if you think about that at a macro level for government, that means governments, whether it's the national, federal government, state, and local, those are dollars that aren't going towards education, infrastructure, job creation. For businesses, that means it's less money for them to invest. And for each and every one of us, that's 20% of our household budget on healthcare. That is simply unsustainable. And if we think about over the last 10 years in healthcare, we've done a lot of regulation, we've expanded access with the promise that this is going to lower healthcare costs. And the reality is that has not happened.
What are the parts of the ecosystem that are not falling in line that you need to fall in line?
Well, a couple of things, I think, in terms of what we're focusing on. We have a great healthcare system, undoubtedly, but we're trying to figure out what are the things that we can impact. And so I'll go through a few of them that we're sort of working on at the CMS level. I think the first one is empowering consumers, making sure that they understand cost and quality as they're making decisions in the healthcare system. The other piece of it is that when we look at what we're paying relative to other countries, there was just an article in Health Affairs talking about the costs of stents and other devices and how we're paying more. And a lot of that has to do with regulation under all the administrative costs in our healthcare system. So one of the things that we have is an initiative called Patients Over Paperwork, and it's really looking at all the administrative burden and the regulation that we've put into the healthcare system. From where I sit, we don't want to decrease access. We don't want to decrease quality. We want to increase those things. And so the solutions aren't around rationing healthcare. The solutions are around focusing on cost effectiveness, focusing on efficiency in the healthcare system. One of the other things that we want to do is lean into technology. I think that there's a future there in trying to figure out how we can deliver healthcare services in a very efficient way. For example, looking at telehealth. One of the things that we just did recently for the first time is having Medicare starting to pay for remote communication technology or telehealth so that they can talk to their doctor over Skype. We can have people take pictures of a skin lesion and send it to their doctor. I think those kinds of things are examples of how we can potentially lower healthcare costs while still improving access and quality.
So one of the things I looked at last night was Arkansas, and the work requirements have come in. Apparently about 4,000 people have dropped out of this, and Asa Hutchinson was out there saying, hey, we've got $30 million we can return to the budget. And I'm just wondering, is that the right dynamic that when you're looking at, say, the Medicaid part of what you're doing? There are a lot of reasons people are in poverty. A lot of people, I think, if I may, I think there are a lot of literacy issues in terms of how to do this. What do we do better that we're not doing to deal with folks who don't have it all together, where there are challenges? And there's this worry about people that there is no further net. And so I guess it's that final net issue. Are we doing enough?
I think it's a great point, and I can tell you from my experience, I started my career working in a safety net hospital. So I worked directly with individuals that were living in poverty.
Right.
And I can tell you that anybody that's living in poverty does not want to be there. They want to have hope for a better future. They don't want to be dependent on the government. And a lot of time they lack those skills to be able to figure out what's the pathway out of poverty. And I think some of these community engagement programs that states have requested permission to implement, that's what they're all about. It's about not just saying, we're going to give you, here's your health care card, good luck to you. We're trying to say, look, these individuals are living in poverty and they need more than that. They need some incentives about improving their lives. And if we think about where we are in our economy, economy is booming. Unemployment is some of our lowest rates that we've seen over the last 50 years. And yet you have so many people that are not working, that are not engaging in the workforce. And I think about community engagement, it's about giving them the skills that they need and matching that up with all the jobs that are available. Governor Hutchinson told a story about an individual that had been unemployed for a while. And through the community engagement program, the requirement, he went into one of these job skills centers and found a job, and he's now earning $17 an hour. I mean, that is what community engagement programs are all about. It's about saying we're not just looking at your healthcare needs, but we're also looking at the bigger picture. And we've had a lot of conversations about things that impact health that are not just about the experience that you're having in the doctor's office, but it's about your whole life. And I think that's what these concepts are about, is helping people, giving them a pathway out of poverty.
Now, one of the trends that I've noticed that I think is part of healthcare reform, and some of it started during the Obama administration, was moving the healthcare system from essentially, I guess, a frequency deal, how many swabs you would give, sort of volume, beds, to wellness and outcomes, and looking at it. Do you see that continuing, or do you see that in jeopardy?
No, I think that's something, we talk about dealing with the healthcare costs in our system. Right. One of the things that we need to do is move towards value. And what that means is the way our system is set up, this is how Medicare is set up, largely is on a fee-for-service system, which means you go in and every procedure, every interaction that you have with the physician is paid for, instead of saying, here's a budget that you're responsible for, and holding the providers responsible for producing outcomes. So value means providing, lower costs and better outcomes. And I think that concept of value is not just at the provider level, but to some degree, as we talk about Medicaid, I think that's where we should be going with Medicaid, where we're making a sizable investment from the federal government, even for states. Number one budget item, number two, growing faster than the economy, our Medicaid budget. the same thing we should be doing with states, which is to say, hold them accountable for achieving outcomes, giving them a budget and holding them accountable for achieving outcomes for the people they serve.
You've been a champion. I've read many things you've read on transparency, accountability, and flexibility. What do those mean to you?
A couple things. I think that for, what we're talking about today is sort of healthcare at the big system level, right? How do we change payment incentives around value, creating different ways of paying providers and even the government or state governments. But one of the things that's very important to me is also impacting the experience that each and every one of us have when we go to seek care. I think that a lot of patients, as they navigate the healthcare system, are often in the dark. We don't know what things are going to cost. We don't know the quality. And we don't always have our healthcare record. And so one of the things that we've really focused on, really doubling down on this concept of interoperability, the idea that every patient should have their healthcare record when they leave the hospital, when they go from doctor to doctor, that they should be able to have their information, and that we should empower them with the information they need to make the right decision that's going to be best for them and their family, so whether it's the cost information or quality information. So a lot of the things that we are doing at CMS around strengthening Medicare program, it's about strengthening consumer empowerment and turning patients into consumers, giving them the tools that they need to make the best decisions.
Your role in healthcare is so huge, and you just mentioned health records, and this isn't in my notes, so I'm making this up. It's such a huge issue and so controversial among practitioners about how bad health records are and the inability to use them through the system. And even reading, I mean, this is across party lines, but Joe Biden's book about his son and getting cancer care, they talked about how Hunter Biden would have to take pictures and do real time to another cancer clinic, in Texas, from where they were in Boston or something like this. And so you would kind of look at these absurd situations where different hospital systems wouldn't use the data of others. You're so large, you're bigger than everyone. Is there anything, outlandish that you could do to up the health record game that we have, to change it, to improve it, so that actually becomes, one of the contributions of the administration to, the overall long-term health care of Americans?
Well, we are, and
okay.
let me go back and tell you a story. And
I didn't know that. I didn't get that note, but that's, so how are you doing that? Because it's really interesting.
And I'll start with a story. So we've been hearing about interoperability, but the whole issue sort of crystallized for me. I had an experience with my husband. He was traveling with our kids. I'm in a different city. And I get that call from my daughter, and she says, Mom, we're in the airport. Dad's collapsed. The paramedics are here. And I get on the phone with
That's quite a call to get.
It was quite a call. And I'm on the phone with the paramedics, and they say, Ma'am, your husband's not breathing. He's in cardiac arrest. Does he have any health care conditions? Is there anything in his medical record? And I thought, I don't know. I didn't know. And it took me a few hours to get to him, and but the bottom line was I didn't know. I didn't have his healthcare information. And then after a week at the hospital, he had all kinds of tests. They didn't know what was wrong, and luckily he's fine. But when we left, I said, because this happened in Philadelphia, we live in Indiana, and I said, I need his healthcare records. Just can you get that for me? Because I'm on my way. I'm busy trying to run run CMS and get this all situated. And I remember the doctor kind of looking at me like, uh-oh. And they came back with 5 sheets of paper and a CD-ROM. My kids were like, what's the CD-ROM? Because we don't even know what that is anymore. No one has that anymore. But it's, the federal...
Did they want to fax it to you, too?
Exactly. They fax the record. So we spent $36 billion, federal government, to have electronic health records. And when people leave, they're being handed paper. Fax machines are still in play. And so this administration is absolutely committed to this issue. We have a lot of support from the Office of Innovation, which is led by Jared Kushner. And we've taken a number of steps. For the first time, we finalized policy that if hospitals are not giving healthcare records to patients, they're going to be penalized. For physicians, where we give incentive payments, those incentive payments we've proposed to tie those to, are you giving the patient their healthcare record? We've also done a lot of our own work within Medicare, where we've said we have a lot of claims data that we have on patients, and we've now put it in an API format. And that's sort of a complicated way of saying we've put it in a format where patients can take that data, We are working with about 700 app developers to develop new and cool apps where they can take their information and it becomes meaningful for the patient. So they can organize their medication lists, they know which tests they've taken, they know which doctors that they've been to. They can take that information, understand it themselves, and they're going to be giving it to their physicians. And if we talk about healthcare costs, for a physician, they're not going to be duplicating tests anymore. They're hopefully going to have enough information that they're giving the right treatment at the right time because they have a complete record. So those are some of the investments that we're trying to make that we hope are going to turn the needle.
Speaking of technology, the other obsession I have about health questions is just the rapid speed of technological change, what we're seeing in the genetics area and the pharmacological area. It's truly staggering. How do you, given where you are and given the government, how does all of that sort of process in to kind of create equitable care and access across people? We know folks with resources can access the very best, but how do these major technological leaps that we're having today finally get processed, paid for, and how can regular people have access to more of these things that are coming online?
Well, that's one of the things that we're focusing on in terms of when we say we're trying to bend the cost growth curve. I mean, I do think that technology has the ability to offer that. We want to make sure our Medicare beneficiaries have access to the latest technology. So we've taken a lot of steps in terms of trying to improve our processes of working with companies that are developing new drugs and new therapies to make sure that we can expedite that. Which brings me to the point in terms of what we're trying to do to strengthen the Medicare program, which is why I think when we have conversations about Medicare for all, I think that's, absolutely a lousy idea. The Medicare program is intended and designed for seniors, and we need to do everything that we can to strengthen the program for seniors, deliver on the promise that we've made to these Americans that have worked their entire lives and depend on this program. We've gone from a program that has focused on acute care. Now it's focusing on chronic care. As people are living longer, we need to make sure that that program is structured and focused on the needs of that particular population.
I know this is a stupid question. I'm going to ask it anyway. I haven't looked at all the dimensions of Medicare for all, and I know it's a political football right now, but wouldn't you, in a way, solve some of the the risk pools, things that we debate about insurance and folks being left out of the kind of spikes in prices in terms of essentially finding a way to bring youthful folks that aren't a burden on the healthcare system in that? Or is that, what is really flawed in that reasoning?
Well, a couple of things. I mean, one, we know, we've seen the estimates. I mean, the price tag on this, some $32 trillion. It's not something that we can afford.
Right.
Dilutes the focus on seniors. But the other issue that I would say is that if we look
well, you go from a $1 trillion to a $32 trillion, yeah.
Well, yeah.
Some administrators would jump at that chance.
Well, I think a couple things. Yeah. What I want to stay focused on is seniors and making sure that they have a program that's going to work best for them. We don't want to dilute the focus. But if we look at the Medicare program, I mean, for years, the trustees have warned about the solvency of the Medicare program. And so instead of trying to fix some of the issues within the Medicare program and strengthen the program, putting more people into the program is not going to solve the problem and actually threatens the focus and the security of the program for seniors. I mean, if you look at the Medicare program, as you said before, it's not a value-based system. We're paying largely on a fee-for-service system. We don't even, if we look at our program integrity efforts, we're reviewing less than 0.5% of all of the claims that go through the system. We have 13 very complex payment rules. We pay for things differently. If you go to one location, we pay one price. If we go to another location, we pay another price. There's no coordination throughout the whole system on the fee-for-service side. So I think what we need to do is focus on strengthening the program, addressing some of those issues, and making sure that the Medicare program is sustainable over the long term so that we can fulfill the promise that we've made to so many Americans.
One of the things, look at, particularly from your perspective, and you see the kinds of trends that are facing Americans today. They're living longer. In many cases, like cancer, we've seen incredible turnarounds in some cancers, promising immunotherapy drugs. One of the, two of the areas that are hitting the United States right now is rapid growth in Alzheimer's, rapid, very big problems in opioid addiction. As you look at those kinds of things and look at how you're providing, what can you do in your role to shape the system so that it can withstand essentially these major pandemics and essentially tsunamis that are going to hit the healthcare system in coming years?
Well, that's a really important issue because I think that I always sort of look at CMS as we're the payer, right? We're at the end of the downstream effect.
But you're going to pay a lot in those cases.
That's right. And so when there are issues in a public health nature, whether it's the flu epidemic or the opioid crisis, we're going to feel it at CMS because we're paying for these services. I think the challenge for us is to not just look at, we're not here to just pay the bills.
Right.
We want to make sure that we are aligning financial incentives to make people focus on sort of the larger healthcare issues. So paying for value, so that we're not just paying, here, and there, but we're creating a system that incentivizes providers to look at the big picture issue. In terms of like the flu epidemic, looking at prevention. Not just coming in and treating the illness of the day, but looking at the whole picture. Is this person prone to, are there addiction issues, and really kind of focusing on that larger issue.
We were just talking off stage about a system where there's too much inertia, too many folks kind of doing things the way they've always done. We had a great piece, which I would recommend those of you who are into healthcare in the Atlantic, and I think she'll be here today. Olga Kazan wrote it. It was a wonderful, wonderful story of a year-long journey, essentially spending time with a woman in Baltimore, a very, very bright light, but had all sorts of healthcare challenges, was below the poverty line, and how the system was just stacked against her. And that despite her best efforts, and you put a lot of responsibility, this is a literate, capable, bright person, and really the bright spot of her family, but whether it was her own family or dealing with city services or state services, it was a miserable, miserable experience, and I still found her optimism great. And I'm interested in those kinds of stories and how you think institutions. You were at Johns Hopkins University, University of Maryland. We were looking at Baltimore and how age disparities, life span disparities were so huge within the Baltimore region, 20 years difference between some places and other, and that's correlated with race, correlated with income. I'm interested in just, step away from your administrator role. Given all you've experienced, what do you think we ought to be thinking more seriously about in fixing that problem that we're not, beyond politics?
I think we need to look at the whole person. I think there's been a lot of discussion about the social determinants of health, right? Understanding that when a person comes into the doctor's office, and it's not just about saying, here's your prescription, but really looking at the context of that person and all the issues that are going to influence their health. I think that's what the community engagement requirements are all about, right? Saying that, we need to help this person rise out of poverty, and to the extent that they have, they're working and they're more engaged in their community, they're going to have better healthcare outcomes. And so I think the conversation is sort of changing, and that's all about going to value, right? Because then when providers and the healthcare system aren't just treating every particular issue, but they're sort of saying, we're going to look at this person holistically. We're going to look at all of the things that are contributing to their health, whether it's where they live, their housing situation, their access to food, and all those things that are going to influence outcomes. I think when we start to change the healthcare system to focus on that, and that starts with changing the financial incentives. We've got to move away from a fee-for-service system and moving to one that goes towards value. When we start paying providers in a different way, we're saying we go in for your knee surgery, we're not going to pay you for every little service within the knee service. We're going to give you a bundled payment. And so you're going to be thinking about how to manage the person so that they're not coming back to the hospital, and when they're at home and they're recovering, that they have everything they need. They have the appropriate support services. So I think it's really incumbent on the healthcare system to change the way we're paying for healthcare, focus on value. And I think by doing that, we're going to incentivize providers not only to focus on the social determinants. You also mentioned technology and innovation. That's where we start to get into incentivizing providers to look at the latest technology and to be innovative. If we're going to depend on the government and CMS to say, okay, this procedure works, and we're going to pay for this, and we're going to pay for that, I think that becomes sort of weighs down the entire system. But moving towards value, where we say, here's your budget, and then providers are incentivized, look at the whole person, look at social determinants, and let's focus on being innovative. Let's use the latest technology and the latest treatments to deliver positive health outcomes and improve that person's life.
We're right near the end, and I could talk to you for another hour on faith in health, health literacy and how you achieve it. We were discussing there's such disparity across the country when you move. I guess I want to give you a chance to take a whack at me and the media. What do you think we're not seeing in this healthcare picture in the way we report about Medicare, Medicaid? You're not exactly in a non-controversial area. What do you think we're not seeing that we might take a bigger look at to help us tell the story better than we are?
I think it's looking at the big picture. You know, we always hear about, you know, sort of the motivations. I know the administration's accused of sabotage, you know. And I look at sort of our record on healthcare, for example, and over the last couple of years, I mean, since we've been in office, for the first time this year, rates in the individual market are going to go down by 2%. We had one of the best open enrollment seasons for the exchange program. And so while we're being accused of sabotage, look at the results, look at what's actually happening. I think also putting together the big picture, focusing on the cost of healthcare, I think that's something that we need to remind ourselves of every day, that as we are making changes, we are making changes for the greater good. We are making changes to sustain the system over the long term.
And I feel I should just ask this to add on. Do you think your predecessors got some things right?
Absolutely. You know, something's right, something's wrong, and I'm sure that folks will say the same thing about me when I leave.
Well, ladies and gentlemen, thank you very much. Seema Verma, Administrator, Center for Medicare and Medicaid. Thank you so much.
My pleasure.
Great, thank you.
Of health equity in America. We're ready for our next panel, and I'd like to welcome to the stage George Benjamin, President of the American Public Health Association, Jeffrey Brenner, founder of the Camden Coalition and Senior Vice President of Clinical Redesign at United Healthcare Community and State, Elaine Batchelor, CEO of the Martin Luther King Jr. Community Hospital, and Garth Graham, President of the Aetna Foundation. And here to lead the conversation, please welcome Atlantic staff writer Olga Kazan.
You can all sit down. Thank you guys. And thanks for coming. Well, we're here to talk about an issue that's very near and dear to my heart, which is the fact that in the U.S., so often how long you live is determined by where you're from. I've written about this topic in Baltimore, but it's also true of other cities. There's a 20-year life expectancy gap between some of the poorest and richest neighborhoods in many cities around the country. I don't know if any of you looked at the upshot on the New York Times. You can plug in your zip code and see, you know, how much a child is predicted to earn in adulthood based on where they're from. So this is really an issue of national importance, and I'm here to talk with some people about how we can go about fixing it. And Elaine, I wanted to start with you because you're in a very interesting situation. You are the CEO of Martin Luther King Hospital, and it used to have a very awful, unpleasant name, which is Killer King. Talk a little bit about how it developed that moniker and what you're doing to kind of turn things around there, and what are some of the improvements that have been made with the new version of Martin Luther King Hospital?
Sure, thank you. South LA, where my hospital is located, is representative of some of the worst health disparities in our country. It's a community of over 1 million people, largely minority, some huge health disparities, and a deficit of 1,200 physicians. It's the location where the Watts riots erupted in 1965 to protest neglect and injustice. And the public hospital that came out of those riots closed in 2007 after struggling for many years with quality and patient safety problems. We have opened a private community hospital in the same location as a result of a public-private partnership. Funding is offered by the public side, and management and accountability for quality comes from the private side. As a result of that, 3 years in, we're building a culture of innovation, of excellence. We are recruiting top talent to our hospital. We've raised over $50 million in private funds. And just a couple of examples of what we've been able to achieve. This hospital, 3 years in, was certified as HIMSS Level 7. That's the highest level of use of information technology for patient care in a hospital, only achieved by 6.5% of the country's hospitals. Despite the fact that we see 100,000 patients a year in a 29-bed emergency department, we're rated in the top 10% for patient experience. So what we're doing is a little unconventional. We're trying to bring first-class healthcare to a low-income, under-resourced community using some innovative models.
And I wanted, just in case people aren't familiar with South LA, one statistic that you told me backstage was that you do several amputations a week, not from war injuries, but from diabetes.
That's right.
Yeah.
From diabetes, which is epidemic in communities like South LA.
And what percentage of your population is on Medicaid?
About 70% of our population is on Medicaid. So what we're doing is unconventional because we all know that there are huge disparities in reimbursement between Medicaid, Medicare, and commercial insurance. And that's one of the reasons we have such a huge deficit of physicians there and the epidemic of chronic illnesses.
So what you're actually talking about is a shortage of specialists in some of these areas because they actually can't make enough if they won't make as much if they move into these areas.
That's
right?
correct.
Okay.
We work closely with community clinics, which do a great job of providing primary care and taking care of moms and kids, but we're taking care of very complex adults, and there's just a huge need for more specialists to help take care of that population. And
you bring in, that's where the private funding comes in.
Absolutely.
To help reimburse
Helping with that.
Mm-hmm. Wow. So let's talk about once the doctors are actually in place. This is a question for everyone. Something that I noticed in some of these low-income communities is that there's not a lot of health literacy, that it's difficult for people to find accurate information about health, that it's sort of confusing. They hear different things from different doctors. What can we do to actually improve health literacy in some of these communities?
So, 36% of Americans are thought to be not at a health literacy standard that they could really make the right decisions about their own health. But if you peel back that onion, it goes really to the issue you brought up earlier, and I think understanding the national picture is about understanding the local picture. Mm-hmm. Like politics, all health is local. Understanding what's happening in each community. And in fact, we published data looking at this earlier that for every $1,000 in difference in median outcome within African American communities is linked to a 5-year difference in life expectancy.
Wow.
Right? So what you're looking at there is a compound issue that actually ultimately lead to the most defining factor. It's just how long you live. Mm-hmm. And so understanding what's happening in local communities when it comes to the issue of trust, engagement, understanding how to deal with their own healthcare, which you explored well in your article, is really about understanding what's happening in a local community. And our thought pattern is really, local interventions, locally measured, national in impact. So understanding what's happening locally is really about understanding the national picture.
So what would some of those local interventions be?
So, for instance, there's this amazing project that we just announced that we're supporting today in Detroit, the Detroit Food Lab. And what they're doing there is linking entrepreneurial spirits to the concept of healthy food. Mm-hmm. And so understanding that if you give people a job, education, a job, and the kind of opportunities to lift themselves up, they are then in a better place to make some of those choices you speak of. And I think of my own life story. I think of the fact that for our family, education was a ticket that keeps on giving. Mm-hmm. And so understanding how these educational and economic opportunities create both a health literate community, but also a health literate family is particularly important.
Right. And I wanted to talk a little bit about this issue of something else that I noticed when I was in Baltimore is that a lot of people don't trust the doctors that they do meet because they've been mistreated so many times. They are sort of reluctant to even go get health care, even when they need it. And I was wondering if we could talk a little bit about how physicians are trained or whether there's anything we can do to improve actually the communication between the doctor and the patient. And it's a question for anyone.
Well, one thing I would say is that it helps when doctors reflect the community that they're treating. Mm-hmm. And we have a very diverse physician and clinical workforce. And I think we're all challenged to bring more minorities into the physician pipeline. The other thing we do is we use health navigators who are from the community, who understand people in the community and can be that bridge between the community and the health system and help build the trust.
Yeah, and this is what Saha published back in 1999 in JAMA, showing that in African American populations, their perceived quality and to some degree their actual quality and Hispanic populations was improved based on physician concordance. So some of this is the data that is scientifically proven. And truth be told, in South Central and other places where you have Drew Medical Center, you have Meharry in Tennessee, you have a lot of places that are producing minority physicians that serve minority communities. And so understanding the importance of those institutions and supporting those institutions, I think, is integral to improving that local community health that we talked about.
Right. And Jeff, I liked what you were saying backstage about physicians being trained more like a priesthood. What does that mean, and how can we go about changing that?
I just want to mention real quickly a study that sort of brings this to a head. They videoed a vignette of 4 patients describing chest pain. So an African-American male, African-American woman, and Caucasian woman, and they gave the exact same description of their chest pain. And even the intonations were very similar. And they showed it to physicians at a national conference. And they asked them, what would you do in response to this? Would you do further cardiac testing? And what we would all hope and what we'd expect in a scientific discipline is the answer would be exactly the same, regardless of whether it was a male or a woman or a man or African-American or Caucasian. And it turned out to follow, the white male was most likely to get the cardiac stress test, then the African-American male, then the white woman, the African-American woman, and the least likely. So that's sort of a staggering thing. Like, that should make you really uncomfortable because we hold medicine up to be a scientific, rigorous discipline. And what you find out is that we're just a reflection of the rest of society. All of the biases, all of the flaws, and all the imperfections that we all have are true in healthcare as well, and in how we train in a culture of physicians. So if you look at the way med schools are run and the tradition, it's much more like a priesthood. If you've ever watched residents and med students follow the physicians around in the wards, literally they're in a line from the most senior to the next, to the next, to the next, the next junior resident to the med student. They even have coats of different lengths that are reflective of where they are in the training. And what the both implicit and explicit direction to the physicians in training is fealty to authority. So it's not a modern, liberal, critical education tradition where you question authority and you question what you're taught. And there's a kind of an unruly process of critical thinking. It's a much older tradition, a much more of a sort of Greek tradition of remembering, of memorization, and of following your leaders and doing what they tell you to do. And there are many ways in which that's worked. You want to watch a physician do a surgery and then try and do it exactly how they did it. But for other problems that are much more complicated, that lack of critical thinking is going to cause a problem.
Wow. Well, and we just heard from Seema, so I wanted to give you guys a chance to respond and possibly get yourselves in trouble with your PR people. What do you think about some of the changes this administration is making to healthcare, both changes to the Affordable Care Act, changes to Medicaid? I know this isn't affecting California as much, but in some places they're talking about work requirements for Medicaid and for food stamps. How will this affect some of these populations that are most vulnerable?
Well, there's no question that some of the changes that they're making are going to mean that less people will have health insurance coverage. Work requirements are regressive. Changes to some of the benefit activity, particularly around immigrants, are regressive. And I think that's the biggest issue. We need to have a system with everyone in and nobody out. Healthcare is not discretionary. And I think until our nation gets to that point that we absolutely recognize that, we're going to have continued problems. Yeah.
What should be happening instead with Medicaid or the Affordable Care Act?
Well, we need to move from a model where they think of Medicaid as something which is a backstop to what it was intended to be under the Affordable Care Act, coverage for everyone who couldn't get coverage through their employer or another system, or could get it in a more affordable way. The Affordable Care Act was designed to do that. And again, many of the things that they've done have really undermined that effort. Now, that doesn't mean that, we clearly should not work with the administration, obviously, to try to improve some of the healthcare coverage activities that they do. They certainly have been very much interested in trying to reduce cost of prescription drugs, been all over the opioid epidemic as a big issue. Which, by the way, we come back to that, but that is a significant, the opioid epidemic is a significant issue in that it's been the major cause of reduction in life expectancy for the last 3 years.
Right.
So we do need to deal with that. But I think if you don't have a system with everyone in, and everyone having access to care, how can you possibly change those numbers?
And since we're at a conference on health equity, I would say that until we have more parity in reimbursement, we will continue to have the kind of disparities that we see in communities like South LA. The average American community has 10 times as many physicians as practice in South LA, and that's related to reimbursement.
And you mean reimbursement between Medicare and Medicaid?
Medicaid, Medicare, and commercial insurance.
Right.
So I would like to see more parity and more equity there so that we can translate that into health equity.
So speaking of hospitals, Jeff, I wanted to talk with you a little bit about how we can balance the kind of quality that you're getting at hospitals, which is often very high, with the price, which is also unfortunately often very high. What are some interesting things that, you mentioned that a lot of states might be doing more rate setting in the future. Why do you think that, and why might that be?
So as Seema talked about earlier, we have the most expensive healthcare system in the world, and we also don't cover everyone. So we're spending a lot of money, and by many measures, we have poorer quality healthcare than other countries. And when you pull off the lid of those other systems, many of those other countries have a national fee schedule. So if you look at cost in healthcare is a mix of price and utilization. Our prices are some of the highest in the world, and our utilization is out of whack. In some cases it's lower, some cases it's higher, but it's often irrational. It doesn't necessarily follow need. So if you go back to price, there's a real irony in healthcare that's challenging. If one hospital in Washington, D.C. does all the open heart surgeries, you want to go to that hospital, and the quality of the open heart surgery will be much higher. If instead you take that same market share and you divide it across 4 or 5 hospitals, the quality in each of those hospitals, because they're not doing as many, will be lower. But if you're an insurer and you're negotiating for price, you actually want to negotiate with 4 different hospitals. If you allow all the open heart surgeries to be done by one hospital, then they can demand a much higher price. So in healthcare, monopoly equals higher prices, but often higher quality. So we actually have a whole history of how to deal with this. This isn't a new problem. You can't have 5 water lines running to your house. You can't have 4 cable TV providers running to your house. So we have a whole history of how to handle natural monopolies that occur. And in healthcare, we've got a tension between allowing for aggregation of cases and one entity getting really good at that, and the inability then to let price float within the system. So we haven't even talked about that, and that's probably one of the biggest drivers right now of increases in healthcare spending is the consolidation of the hospital industry and the inability of the private sector to even begin to address that.
I'm going to take questions from the audience in a minute, but first I want to talk about food, which is a major social determinant of health. And I actually have seen mixed evidence on this. There's this concept of food deserts, which are certainly a thing, and there's been some studies kind of suggesting that maybe they aren't really a huge driver of obesity in some of these areas. At the same time, if you drive around, South Los Angeles, you see a lot of fast food places. You see unhealthy restaurants everywhere. And I think they actually tried a fast food ban there not long ago, and it had kind of some mixed results. So I was wondering whether you guys have seen anything interesting in the food space, either reining in fast food or bringing in healthier food into some of these areas.
Well, one of the things that we're doing in our hospital is we're modeling healthy eating for the community. So we're one of the few places in the community that isn't a fast food restaurant, and where people can come and get fresh fruit and vegetables, whole grains, prepared in a way that is culturally aligned with the community. We've also added food as part of how we treat illnesses. So we know that, for example, people who have congestive heart failure need to be on a special diet. We've started helping provide the food for those folks so that they have access to what they need to manage their conditions.
Oh, wow. So you actually send it to their house? Or
we actually have a program where our doctors write a prescription for food that is then fulfilled by our food services.
Wow.
Food is part of a broader problem. So we have a pretty big partnership with Meals on Wheels where we're trying to get into people's homes to make sure that they have access to the right food. But going back to the statistic that you articulated earlier, in terms of looking at zip codes and how that has predetermined even life expectancy and opportunity in children. I look at my own community, and when I drive through where I grew up, I see liquor store, Chinese food, fast food place, And I see that repeated almost in every sequence in a DNA structure almost.
Yep.
And what that shows to me is not so much that the food is a challenge, but that the opportunities we have where I come from and the opportunities that my folks in my community have are limited, and that's the food is kind of the tip of the iceberg beyond all of that. We have to make sure that we get into communities and deal with the food issue, but we have to dig deeper to the root causes and understanding the root cause of all of these problems. We talked a lot about what's happening. I'm a interventional cardiologist by training, and I'll tell you that what I see is the tip of the iceberg. What we see when we see a patient for an hour, 2, 3 hours in a year is not what they spend the 8,000 hours they spend out in the community. And so understanding, getting to the root causes of these issues, I think, is a bigger issue. So I was happy to hear the administrator mention the concept of social determinants of health. And we should repeat that conversation today when we talk about these challenges.
Absolutely. Does anyone have questions for the panel? We've got mic runners coming around. Any questions yet? I can't really see.
Sure. Oh. Hi, Sydney Etheridge with Planned Parenthood Federation of America. And you mentioned earlier that we're seeing women are having kind of the furthest reach when it comes to equitable access to health care. And I'd be interested in wondering what your organizations are doing to take into consideration the unique needs of women, particularly outside of the pregnancy space, knowing that we'll talk about that later, but women spend majority of their life not pregnant or not trying to get pregnant.
Well, you know, we've been working very hard to make sure people understand that Planned Parenthood clinics provide a whole range of healthcare services for both men and women, and that they're an essential component of the healthcare community. And if they went away tomorrow, there is not the capacity to replace you. So it's, you know, it would cause devastation in many of those communities, as well as the economic, not just the health hardship, but they're also an economic engine for those communities.
Yeah, the infant mortality rate in our country is an ongoing challenge that we need to be focused on, particularly in African American communities. We continue to see widening of that infant mortality gap since the 1980s even till now. And that deals with the concept of preconception care even before you get pregnant, and the driver of very low birth weight and low birth weight, which in Baltimore and DC where we're at, you see some of the more challenging statistics. So what I say, I think it is somewhat repetitive, is we have to understand the challenges that women are facing even before they get into the doctor's office, and how we can make sure that we're providing the right care.
Absolutely.
Hi, my name is Melissa Jost. I am our Director for Clinical Informatics at University of California, Davis Health. And my question is for Elaine. At MLK Hospital, congratulations on achieving HIMSS Level 7. I know that's a really big accomplishment. But I was wondering what sort of technologies you're using to improve patient access, and specifically access to that specialty care.
It's a great question, because one of the things that we did when we started our hospitals, we made sure that the entire hospital was wired for telemedicine, and that's a huge way to improve access to specialty care. When we opened, we were unable to find some of the specialists that we needed in the local community, and we relied on telemedicine to provide access. The other way telemedicine works is on the outpatient side as well, to provide access to specialty care, and then also to connect the different parts of the healthcare system so that patient information travels with the patient and doctors know what's happening with their patient regardless of where they're seeking care.
This woman has her hand up in the middle.
Ellen Milheiser, Synopsis Newsletter. You heard Seema Verma talk about using increased access to electronic health records as a major way of the administration improving patients' access to information. How does that equate to a lower socioeconomic neighborhood where they might not even know how to access this or have the technology to do so?
Well, it turns out that most low-income communities generally have access to the cell phones and the technology. Now, having said that, we still have not only food deserts, but we have broadband deserts what we have to address. But for the majority of people, I think she's right that improving access to the health system and getting your record in is important, and making sure that record is transportable so that no matter where you are on the planet, you can access your health record just like you can your ATM machine. I do think that there needs to be a coordinated effort focused on low-income communities specifically to make sure that Wi-Fi and high-speed Wi-Fi is available so you can get your record, and people being, of course, trained and tooled to how to do that. Now, some of that's generational. All of our kids are much more facile with their toys than we are, but it's also economical. And as the price of those tools, cell phones and technology comes down, more and more people will use it.
I think technology is also a tool, and we have to not get enamored by the tools and forget about the people that we're trying to reach behind the tools. EHRs, AI, all of these various kinds of tools that are now coming into our sphere, we have to understand how to deploy them, not to the worried well, but to those who are most in need. And so understanding how it gets to my community and some similar kinds of places is, I think, where we really need to focus effort, not just on the development of the tools.
They're introducing a new kind of error as well. In Camden, we were seeing high rates of incorrect diagnosis for complex patients. And with the electronic health record, your incorrect diagnoses follow you everywhere. And both incorrect medical diagnoses, and no one cleans up the problem list. So you just, every admission that you go in and out, you just keep getting more and more diagnoses attached to you. So one of the most common incorrect diagnoses that we saw was bipolar disorder, so which results in incorrect medication. So there were patients that really had early life trauma with depression, and the irritability that they would express if they yelled at someone in the healthcare setting, suddenly that got translated into bipolar disorder with the wrong medicine, and that sort of following them around. So I'm really worried about the implications of these technologies, and we don't think enough about, technology just accelerates bad care if we're not thoughtful about the kind of care we're delivering.
Well, unfortunately, that's our time, but thank you so much, you guys, for taking on this huge issue, and thank you all for being here.
Thank you to Olga and all of our panelists. And now we're moving on to our next session, produced by our underwriter. We're going to make a quick transition of the chairs here for just a second. Great. Delighted to welcome to the stage Steve Nelson, CEO of United Healthcare, and joining him is Alexis Glick, CEO of GenYouth. Welcome to the stage.
Good morning, and thank you for having us. Good morning, Steve.
Good morning.
So it's been a fascinating discussion. We've heard a lot about the theme of health equity. Share with us how you see health equity and how you think it has been redefined and shifted over the past decade, and why.
Oh, sure. So it has been an interesting journey on this topic, and somewhat I'd say I'm somewhat frustrated by the lack of progress in it. I don't know if anybody is with me on that, but I started my career in healthcare about 30 years ago with a public health background, working in inner city Detroit, early 90s, late 80s, launching managed Medicaid into the inner city setting, and got to see the need and the issues, very, very close up. And I would say now, fast forward 30 years, it's sitting here in 2018, the issues have actually intensified, in my view, and the need has grown. And there's a lot of reasons for that. From our perspective, from United Healthcare, we have this kind of unique view across the healthcare continuum. But first of all, there's a lot of macro demographic trends that obviously are adding stress to the system. Aging population, more chronic diseases, and then we have this incredible dynamic in our economy where we're spending almost 20% of our economy on healthcare, but the way we spend it is backwards. 80–90% of our health issues come and are caused by issues that are outside the traditional healthcare system that you've just heard talk about social determinants of health and other things, yet only 20% of our spending goes towards those things. So that equation is wrong, and that continues to be set in motion unless we do something very dramatically to change that. So I think that is a factor. And then you think about the social determinants of health, and I know a lot of people in this room live with these statistics every day and are very well versed in it, but these kind of blow me away. This idea of 40% of the food produced in the U.S. is wasted, but there's 41 million Americans that live in a home where there's food instability, where almost half the babies born in the U.S. are going to be born into a Medicaid family, which means they're going to be born into a family that's earning less than the poverty level, which creates health inequities just by definition. And so this idea that we have a healthy economy and low unemployment, it hasn't seemed to help this, and so it has it's gone from a peripheral kind of an issue to absolutely central to changing healthcare in this country. So it's only intensified.
It's interesting. I know you very well, and I've heard you talk a lot about redefining access to healthcare. And I think for a moment, if you could share with us, how do you define that? What do we need to do to redefine what access looks like?
Sure. So I think this is a really important conversation, and it's not just semantics. It starts with a way of thinking about health and healthcare, and we're traditionally called, or people call us a payer of healthcare, and I actually spend most of my time thinking about how to actually redefine healthcare and to Administrator Verma's point, pay for it differently to create different kinds of behavior and more of a system. But the idea that this idea of 80% of our health is affected by things that happen outside of the doctor's office and the hospital, yet we don't traditionally think of those services as healthcare. And so it starts with a redefining in our own heads that food stability, education, housing, transportation, more of the mental health sort of capabilities in our country need to be brought into the mainstream of the healthcare system. That requires a different way of thinking. It requires a different investment. It requires more attention to strengthen these really important components. And again, I think we used to think of them sort of peripherally, and now they need to be a central part of our healthcare system. So redefining that is as much of a activity as it is a mindset, and I think that'll be really important for us to do.
As someone who's been in the industry for 30 years, you've seen a tremendous evolution, and yet I know that the statistics you shared earlier are the things that keep you up at night. Yeah. So this opportunity to redefine access and this opportunity to bring all of those clearly global health issues to the front and center to help us think about the go-forward strategy. Talk to me about that. What does that mean to you when it keeps you up at night? How do you define what success looks like?
Sure. So we believe, and I personally believe, and our organization believes, that we can make a difference. So I'm optimistic. I'm hopeful. I really appreciate the conversation and the attention to this issue. And so, we, for example, this idea of thinking about the components that aren't traditionally part of the healthcare system, we have started to invest in those deliberately and to try to bring them into the mainstream. And we don't do it just for United Healthcare members. We've actually set a goal to redefine and create better access to health for 1 million additional people every year outside of United Healthcare. And that's going to be through strengthening these community partners that exist in the community today that are just kind of hanging on and just barely making it, but adding such incredible services, whether we're talking about food banks or community health centers or federally qualified health centers. The list goes on, but there's a lot of folks out there who are struggling and really trying to do this, but don't have the right kind of resources, infrastructure, and funding. And so we're trying to bring some of that and strengthen partnerships, because it really is the case in this situation that, in this one of our favorite phrases, 1 + 1 + 1 can equal a lot more than 3. And in this case, it's really true that we have an opportunity through partnerships to really do something extraordinary, because none of us can do it by ourselves, even though we have I lead a very large healthcare organization, but we can't do this by ourselves, and we need all kinds of partnerships. And again, I think our mission is to help people live healthier lives and to help the health system work better for everyone. And so to live that mission, we are getting after this, and we're going to stick with it. And I really appreciate the opportunity to be here, be part of this, and to participate in the conversation.
When you think about that mission and so core to your DNA and how you can change the trajectory of the access, just as you said, 1 + 1 + 1 is far greater than 3. And it takes bringing unlikely partners to the table to really do that effectively. As you go about tackling that and talking to folks within the community and leaders within healthcare, take us forward. What do you see the opportunity being? Is it addressing those 28 million uninsured individuals? Is it addressing those who have access and thinking about prevention earlier?
I think it's all those things, but I think this idea, and we heard Administrator Verma talk about it, heard the panel talk about it, and this idea of until we start thinking about healthcare relative to the whole person's experience and their environment around them, then we're not going to fix this thing. And so organizations like ours, organizations that you all represent in the room, we have got to kind of come together in a way, and I'm fond of this phrase too, which is blur the lines. We cannot be so hung up on the traditional boundaries that we have found ourselves in. And so payer, hospital, community center, all these lines need to get blurred so we can create more of a system around the whole person. And I really do also believe in the idea of moving from kind of a volume-based approach to value and outcome-based approach. And we have all the tools now. We have the technology, we have the data. And so this is going to happen. This transformation is going to happen, and we're all part of it. And so, it's time to, again, come out of the wilderness into the mainstream and be part of the central healthcare system. And it's a very exciting time, and I think the transformation is real.
Well, thank you so much, Steve. We're excited about it, and thank you for sharing your vision and your mission and what United Healthcare intends to do about it.
Thank you. Appreciate it.
Thank you, Alexis, and also to Steve. And up next, to discuss the social determinants of health, we're going to welcome to the stage a few more panelists. Wendy Ellis, Project Director of the Building Community Resilience Collaborative at George Washington University. John Rich, Professor at Drexel University and MacArthur Genius. And Alexa Quinn, CEO of Health Leads, and they are here with Atlantic staff writer Van Newkirk. Thank you. Welcome, everyone.
So we're talking about the social determinants of health. That is a very big phrase, and we talked about it backstage, and it means just about everything. So I want to ask each of our panelists sort of what social determinants of health mean to you in your profession and in what you do every day. So we'll start with Wendy.
Sure. Social determinants, big word. I'm not quite sure it really captures what we're talking about here. And so when we talk about social determinants, unpacking the word is probably most important, and understanding that what we're looking at are these disparate outcomes in communities that are really systems driven. And so unless we actually are quite explicit in understanding what are driving those so-called social determinants, we have to really think about the institutional racism and systemic inequities. So social determinants that are associated with poverty, associated with inequities in access to affordable care, or access to affordable housing, those are the things that are driving these inequities with regard to educational outcomes, and then they're also associated with health outcomes. So I prefer not to use the word social determinants, quite frankly. I prefer to be quite blatant in understanding that what we're talking about are these outcomes that are associated with inequities.
So we should just call this panel inequities. What about racism?
About racism.
Racism.
Absolutely.
Let's
just call it racism. Right. Yeah, you can't fix it if you can't say it.
Panel over. John.
So I couldn't agree more. The fact is that we know that all these structural factors, education, economics, not only constrain how people can access health care and other services, but we know that they actually themselves can cause changes in the body that lead to disease. Okay, so in our work, we're often working with young people who have been victims of violence who are seen in the hospital for a gunshot, stab wound, or assault. And the hospital is really good at fixing their physical wounds and ignoring their psychological distress. But these young people also come from communities where there are high rates of poverty, where they haven't had access to education, where they often don't have access to employment opportunities, and where they are constantly under the stress and threat of police racism and other racism in the community. So if we only in those settings pay attention to their physical wounds, we haven't really addressed all of these other factors that relate to their health. And so the social determinants of health is really about an individual patient at the moment we see them, but more than that, it's about the population and the communities, all of whom are affected by these structural forces, racism, again, prime among them, that affect not only the health of individuals, degrade the health of the individual, but also affect the health of the entire community.
So following up on that, is there a way for some people where this works in reverse, where the social determinants don't degrade their health, but actually improve it, give them a better structural foundation?
Well, it's actually a good point. The definition that we use for racism is the one that Kamara Jones uses, which is it's a system that unfairly disadvantages some people based upon the color of their skin and unfairly advantages other people and saps the strength of the whole system. So it hurts all of our health by this inequity.
Okay. Alex.
So my name's Alexandra, and I'm the CEO of Health Leads, and Health Leads has been focused on social determinants for over 20 years, and we recently redid our mission to talk about systemic issues. Because we had this realization that it doesn't matter how good your intervention is within a hospital, in a community, if you're not addressing systemic racism, it's not going to change anything. So Health Leads is focused on addressing systemic issues of inequity and disease, and then we do this by removing barriers to identify, choosing, and accessing essential needs or social determinants. And social determinants itself is such an inaccessible word, and we actually asked our patients, our patient advisory council, like, what would you rather call it? And they said essential needs, because social determinants is not accessible. There's nothing basic about needing food or utilities and housing. These are essential needs, which means we also have to focus on the barrier removal around racism and institutional and individual and systemic racism.
So what do you find when you're doing these surveys of people, when you're asking them, what are your essential needs, essentially? What are the most common barriers that you are finding? Are there things that stand out more than others?
I mean, it really depends on the community, and I think we've seen a surge in addressing essential needs over the past 5 years. There's actually a market now, and I think what we really tried to go back to was, let's think about this in terms of communities. So how do patients and community-based organizations and healthcare systems work together to identify what their needs are? So in one of our regions, we actually brought together 5 healthcare systems, community health workers, and patients, and said, what's the most important essential need to you right now? And they picked housing. It could be food in another place. But really, me sitting here and naming that for an entire country, it doesn't actually serve the people that we work with.
Housing, Wendy, something there is interesting to me, because so many things to do with housing are also associated with this body of literature that's really impacting the mainstream now about ACEs. Tell us more about ACEs, factor in your work and what they mean in this conversation.
Absolutely. So I think John was sort of alluding to that with understanding how this adversity that happens to individuals throughout the course of their lifetime, it literally gets under the skin. So we are talking about understanding how adverse childhood experiences, which you refer to as ACEs, things about with regard to adversity, whether that's within the household, instability, parental substance abuse, which we're seeing, Dr. Benjamin spoke about that earlier on the earlier panel with regard to the opioid crisis, but understanding that adversity comes in multiple forms and isn't just at the individual level, which I also think you were discussing as well, that what we talk about in our work is the pair of ACEs. So it's adverse childhood experiences in the context of adverse community environments. So when we're talking about housing playing an essential role is that stability for that family, for that individual, but also stability for that community. And there is not a one-size-fits-all. I agree with you. In some communities, it could be housing, it could be food insecurity, but understanding that essentially the tone, the nature, the outcomes of our communities are so based in housing. And when we talk about the #1 sin, where a lot of this started from our communities and disproportionate outcomes, it is not by accident that you have chronic adversities all segregated within certain populations, certain zip codes, because that was actually baked into our system with the early policies with regard to segregation, how we financed our housing industry. The policy of segregation was set in place. So now 50, 60, 70 years later, when you see this cycle of oppression and this cycle of negative outcomes for individuals, it is baked into the system. Our system is doing exactly what it was designed to do. And so in order to really change outcomes, reverse the adversities, we have to think about our system's design. And we have to be really deliberate in redesigning that in order to have different outcomes.
John, I feel like that was tailor-made for you to follow up to. So we talked about the system and really getting into sort of how things are designed and how they pretty much without fail lead to these poor societal outcomes. Tell us more about that, and especially in the context of black men.
Sure. We talk about institutional racism, systemic racism, structural racism as that's built in. That almost regardless of who is leading the organization or the system, it's built in, so it's going to continue to perpetuate, often in quite diabolical ways, the outcomes that the leaders of the organization might say, well, of course we're not a racist organization. But if you haven't rooted out and tried to identify how these problems came about, obviously from the historical oppression, then you haven't really done the work. So, for example, if you think about the fact that one of the ACEs, the adverse childhood experiences, is having a parent who's incarcerated. And we know that there's a relationship between adversity in childhood and your risk of chronic disease. Well, there were a whole set of policies put into place to ensure that black men would find their way into the criminal justice system through sentencing policy, drug policy, and then a whole set of policies that followed after that with mass incarceration that ensured that those people emerging from those institutions would be unable to find work because of felon disenfranchisement, and they would be cut off from participation in the democratic system. And so if you think about these policies as not only impacting the opportunities for those men or communities of color, you can also think about the relationship between mass incarceration and chronic disease. So black men have the lowest life expectancy at birth of any other race, sex group. So these things are entangled and complex, and yet they often trace back to these structural forces. And healthcare has a role to play. Maybe we'll come back to what we think that looks like.
Well, okay, so when we're talking, we like to have this conversation in the context of healthcare, but it's clear that these are things that have to do with other policy, with politics. You can pretty much attach a value to every detrimental policy decision, and that shows up in the lifespan, right? Alexandra, you were talking about the interplay between the healthcare system and education before. I wanted you to bring that point back here Because I do think when we're having this general conversation about social determinants, it's one that we cannot have solely in healthcare circles.
That's right. So what I was saying before was I spent 8 years in education before spending 10 years at HealthLeads, and what was fascinating to me is in education in schools, you know, you talk to any teacher, any parent, racism is there every single day. In healthcare, often there's a 10-year study to discover that a policy is racist. And how do you mix the two? How do you have the urgency of education with the diligence of healthcare? And for HealthLeads, one example of exactly what John was talking about of, you know, there's the big P policy and then there's a little p policy and process, and both have to be changed at the same time. And we work with women, infants, and children in New York, and that is actually a benefit that New York wants moms to be on. And so we have community health workers who are working within a healthcare system, and they are both working on the individual of how do you enroll more women into WIC. And what they're finding is that there is huge drop-off. So there are 400,000 women each year who could actually enroll and be eligible for WIC who don't. And that has nothing to do with well-meaning people. That has to do with major drop-offs and identifying, and then actually small things like, how about you speak the language when the person shows up for their appointment? How about you don't require 4 appointments to actually get on this benefit? And so those are the small P policies that end up being quite biased and that we could actually change. And then the last piece is, how do you actually understand an individual's needs, you know, in the context of their community, in the context of their race, and then tailor what you do for them, which I think the healthcare system is not set up to do right now.
I'd like to build on what you're saying here, because there is a role for healthcare much beyond the delivery of healthcare, and sometimes that is just being that neutral arbiter, because a lot of our healthcare providers really do have trust, and particularly in disadvantaged populations. And so an example here in Washington, D.C. is that we were working with a group of physicians who really understood that there were a number of different contextual issues that were facing their patients to achieve optimal health. And so physicians were thinking, well, perhaps we should bring a farmer's market to the hospital here so that we can have access to food. And they asked our team to go and talk to the patients to find out, well, what are the leading barriers for you achieving optimal health? And out of all of the focus groups and all of the key informant interviews, the #1 barrier to optimal health were their interactions with Metropolitan Police in community. The second one, every woman that we spoke with had a history of sexual violence. And so those are things that if they were willing to talk to me about that as an outside entity, and at the healthcare facility, I know that they would be willing to have that conversation with their physicians, because their physicians said, hey, this is a safe person for you to talk to. We really want to get to the bottom of your health barriers here. So out of that, you know, because of their relationship with Metropolitan Police, because they also provide primary care to individuals within the DC jail, so they see them when they're incarcerated, they see them when they're in custody, in community. And so they were able to use their position to bring these parties together. And so that's our next piece, is to actually facilitate this dialogue between police officers, between the patients, to try to find how do we reduce these stressors. As John was saying, these things literally get under the skin. That's not the delivery of health care, but that is definitely delivery of a prescription that the community needs.
Well, there is not a policy problem that exists for which people have not prescribed a farmer's market to fix. Wendy,
we can't eat our way out of this one.
Or parks, don't forget about parks.
Oh, parks too,
yeah,
yes.
Parks too.
But Wendy, I did want to, in the research about social determinants and looking at who's coming up with the concepts, it seems to me that a lot of this conversation, it's sort of cutting edge for some folks, but it's the way that black folks, especially black women, have always talked about health, about how their health works, about what they need. How can we bring those voices who sort of know what they're talking about, who know what this discussion is about, into the conversation? Get more folks who are not just talking about their own experiences with sexual assault with the police, but actually putting that into a place where it can be turned into policy.
Yeah, so that's exactly what our project is doing across 5 cities across the country, is bringing that community voice into this process, not crunching our data from our systems. You know, we're really good at identifying the #1 priorities based upon our utilization data, but really bringing that community voice into the process to inform what are the, #1, do we have the same priorities in mind? And number two, what are the solutions? There is so much wisdom in the community. What we're finding is that that Maven network, and I grew up in one of those neighborhoods where, you know, grandma was not just my grandma, but it was everyone else's grandma too. But they had such deep wisdom with regard to not just behavior, but also working the system. I mean, Black women in this country, we have fought against both systemic racism external to our community, but also there's been some misogyny that we've had to deal with within our community. So we've had to straddle both lanes. We know what we're doing, and we also have a lot of caring, a lot of experience from an educational standpoint. So bringing the multitude of voices to the table, sharing in that wisdom, using the qualitative data, which is just as rich as the quantitative data that we get to our systems, to really get to something that is not only serving the priorities of the community, but is going to be embraced, is going to actually have sustainability because there is an ownership of that. And so that's what we've done. You know, in Portland, Oregon, it has been bringing that parent voice into really designing the redesign of the public school system and how they're delivering services to community. It's also being a part of this advisory board that we're putting together here in Washington, D.C. It's having sweat equity in the solution.
So we have a big room and lots of folks taking notes. So I know we're going to have some good questions. So cue those up, and I'll come back to you very shortly. I want to, in my questions with John, I followed your work for some time. I'm admitting that right now. But one of the interesting things about it is you in your search for solutions and your look at novel ways to address social determinants, a lot of it's focused on sort of rebuilding civic engagement, getting communities, sort of obvious ways of getting communities to speak to each other about health. Tell us about that. Leave us with, I guess, something positive.
Sure. You know, it's always been a community of us working together to try and think about where these conversations might lead us astray and where we can do something more positive. So the challenge of the social determinants conversation is that folks hear it, but they often then look at the individual and say, this person needs to get themselves together. I think we heard some of that earlier. So the question is, how do we understand the social determinants, but also understand the incredible potential and power that these young people have within them? So we're working with the Robert Wood Johnson Foundation, Forward Promise Initiative, and our rallying cry is heal, grow, thrive. So we understand those structural forces, but we're also thinking about how to heal and grow and thrive. And so our work has turned to identifying this incredible pool of talented young people in communities to train them up to be community health workers and certified peer specialists, to create a community of practitioners who can work side by side with us. Just to what you were saying before, they may not have the language of social determinants, but they understand how it's impacted their lives. And they are the most invaluable co-providers with us. Now, our systems have to change. Our hospitals have to change to accommodate them. Our reimbursement systems have to change because we don't pay for their services. But we have a tremendous opportunity, if we understand that these are social and not individual forces, to think about all of this untapped potential that exists in the communities that we're striving so hard to improve the health of.
All right, questions? Let's see. All right, I'm right there.
Good morning. My name is Eloise Gadsden, and I'm a retired social worker, and I've worked in New York and Boston and Baltimore. I tell people I used to work under the ghetto. And I hear you talk about all these programs, but the money isn't there. The money is in medical services. And we've struggled with including behavioral health, substance abuse, and mental health in that medical umbrella, and they're still fighting it. There's still only 10 sessions or 20 sessions to somebody who's been getting high for 20 years and has 3 kids, and one of them has developmental disability, and all of that range. When they get out of that hospital, there's no money. And if they don't have Medicaid, which in many states they don't, there are no services. The models and the policies are there, but nobody is going to pay. Nobody wants to pay. And hospitals may sponsor programs, but the money goes to the medical aspect, and you have to fight tooth and nail on the phone trying to get 2 extra sessions or 3 extra sessions. There's a gap between all of this and what's actually going on the ground.
We should put you on the panel.
So what are you going to do about it? How are you going to fix this? Fix it!
Anybody?
I just would, you're right, and there are not models that serve the level of need that the young people and others that we're seeing. I do wonder, what if health systems were held accountable, or their success was measured by those also? So we've talked about, right? So the things they solve for, health systems solve for the things that they get paid for, reimbursed for, but we've often talked about, what if it was on a hospital in a city to, you'll be, part of your performance will be evaluated on your ability to decrease trauma and violence in a community. Now that would require some innovation and some thinking, well, what is our role? Because right now everybody's pushing it off, it's not my job. But I think that the systems could figure something out.
Can I just piggyback, because you use plural systems at the end there, and I really want to push back hard on our thinking. We're all creative, really smart people. Why is this just a solution for the healthcare system when we know that the healthcare system alone did not create the conditions in which you just described? An individual that has a 20-year addiction issue, there's a lot more going on there. There's a housing issue, there's an education issue, there's a law enforcement issue. Where are we talking about responsibility across multiple sectors? So no, the money should not all be held in health care, because health care alone cannot solve what we're talking about when we talk about social determinants. We are talking about issues that cut across multiple sectors, and why aren't we asking housing? Why aren't we asking criminal justice? And why aren't we looking in their pots as well?
Question over here.
Hi, good morning. Heidi Schoonmaker with the VCU Center on Society and Health. Thank you all for your work in addressing the social determinants. I'm interested to hear about your strategies for success, how you're sharing those either with the public health community and healthcare at large, so we're not reinventing the wheel, or with policymakers. How are you getting your data in front of them, those community voices in front of them, so that you can change the policies? Thank you.
So that is the project that I run, actually. While it's housed in an academic institution, we're taking quite the alternate route to academia in the sense of we're doing real-time translation. I'm not so much concerned about turning out as many peer-reviewed articles that my peers can look upon and say, oh, wow, she's really phenomenal. I'll get to that, but what's more important is really answering to the needs that are striking and really hurting our communities today. And so we take those voices, we create those programs, those policies, both small p and little p. And we've had some policy wins at the local level as well as at the national level, but taking those voices to Capitol Hill. So our website, all of our tools, our resources, everything we put out there. So for other communities to really adapt it, I'm available by email. I actually answer my emails. My entire team answers their emails. The communities across the country, we are open to collaborating because there is no time to wait for someone to review, to do an RCT. The need is real. Let's get to it today.
Alexander?
Yeah, and same for us. For Health Leads, we have 1 foot in actual practice and 1 foot in accelerating practice. So what that means is everything that the panel's been talking about, think about the WIC program I described. It was actually our community health workers that talked to the state of New York about the issues within the WIC process. And so what we try to do is how do we spread the learning both to impact policy on a state and national level, and then we run learning collaboratives across the country. We have one right now, which is 22 healthcare systems across 12 states, and they're all 2.0 on social determinants, so how do we bring them together to learn from each other? And right now we're also focused on how do we do a better and broader job of bringing community voice to change these issues, because I think that also for our retired social worker, that's also what's going to change.
Mm-hmm. More questions, more questions. One right here? Oh, yeah. Okay.
Yes. I'm Dr. John Dykers from a little town called Siler City, North Carolina.
Yeah.
And You know the area?
I'm from Rocky Mount.
Rocky Mount?
Yes, sir.
Not too far away. I'm looking about, and I was thinking I'd best apologize for being an old white man. I don't see any others in the office. But I practiced medicine in that small town until 2010, from 1964. So that's a few years, and saw about 60,000 people. And I would like to suggest a major, or at least a minor redefinition of racism, if I might. That racism is treating any of us, whatever the color of our skin, as though we were all alike. And that is not true. And the other thing is that you often speak of racism as a matter of skin color. And it is as much or more so a matter of speech. We are recognized as much how we talk. And I think of code switching, and you talk about the people who have failures in functioning in society. And we found that about 40% of the folks reaching 4th grade have learned automatically to code switch. And I'm assuming that you know what I'm talking about with code switching. And code switching, for those of you who don't, is switching back and forth from African American English to general English. And I ran into this personally when we got to voice recognition software. And I had a colleague I had brought in to take over my practice as I was nearing 75 and needed somebody younger and brighter to do the things I was doing. And Dragon Naturally Speaking, we tried to learn how to use that to keep our medical records because they are such a god-awful mess. And Amir Javed had trained in Pakistan and Britain, and he spoke to the general medicine vocabulary in Dragon Naturally Speaking, and it would reproduce it just fine for him. And when I tried it, it was just pure gibberish. And so I decided that I needed a new vocabulary that was general medicine Southern.
So you use a new vocabulary. I think we can actually take that, we can close on that when you said, we can redefine racism and talk more about social determinants from that model. So what's your name again?
D-Y-K-E-R-S, John Dykers.
From Siler City?
From Siler City. I grew up in Jacksonville, Florida.
Well, nice to meet you, sir.
It's nice to meet you from Rocky Mount.
Thank you.
And my son just turned down a job in Rocky Mount. It's having a hard time lately.
Well, tell him to come on by next time.
Okay.
Well, and thank y'all for coming. And thank you, Alexandra, John, and Wendy.
Thank you, Van, and to all our panelists. And next, a conversation about maternal and infant health in America. I'd like to welcome to the stage Maria Gomez, President and CEO of Mary's Center, Stacy Stewart, President of the March of Dimes, and Bonita Stanton, Founding Dean at the Hackensack Meridian School of Medicine at Seton Hall University. And here to lead the conversation, please welcome back Olga Kazan again. Thank you.
Thank you. Hello again. Okay, so we've got to talk about a really shocking statistic right now, because the data show that Black women are 3 to 4 times as likely to die from pregnancy causes as white women are. And that includes Black women who have a high level of education. In fact, the US is only one of 13 countries in the world where the rate of maternal mortality is now worse than it was a generation ago. So we're here to talk with some folks who are working on this, who are trying to fix this issue, and try to figure out what we can do about it. So first I wanted to start with you, Dr. Stanton. You have an interesting backstory in that you worked in Bangladesh kind of many years ago, and I was wondering, what did you learn there? How do you apply that to your work today?
What a great question. And it is become actually the thread that has gone through my whole career. When I went to Bangladesh, it was a young country. It had just suffered a major typhoon. The rural areas were devastated, and so there were huge migrations up to the urban areas, including Dhaka, where I lived. And I was teaching the communities how to use oral rehydration solution. And the women I was working with had zero education, not even first grade, zero. And so after working with them for a couple of months, a group of them came to me and said, why are you just teaching us how to treat diarrhea? Why aren't you teaching us how to prevent diarrhea? And I thought, all my years of education, and I didn't think of doing that. So I then looked to see, okay, what do we do? What do we know that's really easy to prevent diarrhea? And the laundry lists were not evidence-based and went on and on. Wash your hands, don't let flies get to the food, wash your kids' hands, on and on and on. And so I brought this list in the next day, and we went over it, and all of them kept coming back to needing water to wash your hands, to wash the kids, to wash everything. And eventually one of the women turned to me and said, but we stand in line for 30 minutes to 2 hours every day after walking half a mile to the pipeline, the pipe stand. We can't possibly use that much water. So I thought, she's right. But then someone else observed, and yet we know some of our neighbors have really low rates of diarrhea. Others have very high rates. Can't we do some sort of a study to figure out what they're doing differently in this community? And I thought, wow, not even first grade, and she's describing a case control study. So that's what we did. We eventually did a major case control study followed by an intervention based on the findings from that, a longitudinal study, and we significantly began to change the rates of diarrhea with this simple maneuver. And so wherever I have been, I came back to Baltimore, I was in West Virginia, I've done a lot of work in other settings, I realized you don't even begin thinking about treating a population until you have spent time working with that population. And you let them feed into everything that you're thinking of doing in medical care, because time after time, they'll be so much smarter about this than you could have been.
Yeah, absolutely. Well, and we recently got kind of a hint of this issue that women of color face with pregnancy and postpartum care with Serena Williams, actually, who had a pulmonary embolism, and she had to famously wear the cat suit, playing tennis instead of the standard tennis whites, and it caused a big brouhaha. I was wondering if we could, just so we all kind of understand, what are some of the factors that go into these high rates of maternal mortality and the pregnancy complications among women of color? And anyone can answer.
Yeah, I can start. So right now in the U.S., we have the worst rates of maternal mortality of any developed country in the world. And that makes the U.S. the most dangerous developed country in which to deliver a baby and to have a baby. And of course, the rates we know are far worse for women of color, especially for African American women. So there's 700 women that die as a result of childbirth every year in the U.S. But there are 50,000 women who become severely, who suffer from severe morbidity. So they're what we call near misses. They are so severely ill as a result of childbirth that they almost die. So the issue is actually far, far greater than even just the number of women who die, although 700 women who die as a result of childbirth in 2018 is appalling. And our rates have doubled over the past 25 years. So what we know is that about 60% of these cases are avoidable. 60% of the cases are cases that should be and can be treated in the hospital or by a healthcare provider. We also know that for women of color, as you mentioned, irrespective of income and education, that Black women are far more likely to die as a result of childbirth or become severely ill as a result of childbirth. And what we also know is that that often is because of chronic diseases that those women suffer from, diabetes or hypertension or other chronic diseases, also cardiovascular diseases. But there are a range of other issues as well, things like embolism and pulmonary embolism and sepsis and infection, a whole range of other things. And of course, the last thing is that we know with the rates of substance abuse, substance use disorder in this country, we know that more and more women are suffering also from mental illness and are not getting the help they need in terms of dealing with addiction and other kinds of challenges as well. So we have a big challenge on our hands. The fact that we're looking at this issue now is great, but there are some solutions we can start to put in place today and then ones that we need to work on as we move forward.
So I would just like to add that part of what Stacey's talking about is also sort of as a healthcare system. I run a community health center, a federally qualified health center that we need to continue to be held accountable, right? As community health centers, as physicians, private practice, and making sure that we are really answering to the needs of women when they need care. Statistically, we know, probably in this room, if you are trying to get prenatal care, it probably take you 2 to 3 months to get your first visit. If you're trying to get a family planning visit to prevent that pregnancy, it will probably take you much longer. If you're just trying to get your doctor, it's going to take you much longer. So just for chronic disease. So I think that we need to really be conscious and be loud and be held the medical organizations accountable to us as individuals to make sure that we're meeting the needs. And then once we walk in that door, we need to make sure that we are accountable to that individual, that we are actually introducing them not just to the care, but also to the community so that they can have the resources, as has been said all morning long, about dealing with the determinants of health. Because many of the issues that we're talking about really are the issues of poverty. And if we're not dealing with those, we're not ever going to deal with it. But we also talked about medical records. And medical records, we're so sophisticated, and yet we're not communicating. Our records are not accessible. And so chronic diseases get missed. Sometimes we're not even following up because people are not telling us the urgency of our chronic disease. Oh, you have prediabetes. Here's a diet. Take care of it. That's it. But that is like a predetermined factor for when you get pregnant. That is probably going to be the one that's going to be harmful to you.
I'd just like to add one thing. I agree with everything that was said, and I think that, once again, we have a situation where poverty is so important as a determinant. But one of the really troubling things about this, as we all know, but we have to remember, is that this is a problem that goes across all educational and socioeconomic classes. So there was a very famous paper back in the early 1990s in the New England Journal of Medicine that realized that if you looked at the death rates of college-educated African-American women in childbirth, they were comparable to those of 8th grade Caucasian women. And so this suggests that what we might be seeing are perhaps epigenetic effects, that we might...
Really quick, what are epigenetic effects?
Oh, I'm sorry. These are effects on the changing of the gene over time by environmental influences, so that gene is turned on or turned off in a certain way. By things that means that something that was impacting your grandmother could still be having some effect on you. So it's a very complex disorder, and everything we've said is true, but this one's even more complicated.
No, I think that's right. It is complicated, and I just want to say that absolutely I agree with you, but I think that we still need to make sure that we don't use that as an excuse not to do some low-hanging stuff that needs to be done.
Absolutely. Yeah. Well, I wanted to ask about, so a major problem that the Atlantic has actually looked in with a video is maternity deserts. So it's this idea that it's actually, in parts of the country, it just takes a really long bus ride or a really long trip to even get to your OB-GYN appointment when you're pregnant, which is, a huge problem. Where do these maternity deserts come from? How big of a problem are they?
So I was really inspired, actually, when the Atlantic did a story about maternity care deserts here in DC. Because I think one of the things that has been well documented are the lack of obstetric services in rural areas, the closing of hospitals, and we know that, and it's significant and it's real. The fact that we're also looking at maternity care deserts in urban areas, highly populated areas where there are presumably sufficient numbers of resources or amount of resources to serve women in an area, and women still don't have access to care. So here in DC, Ward 7 and 8 east of the river, there's no hospital. And the story in the Atlantic talked about a woman that has to go and travel without transportation, has to go all the way to Washington Hospital Center just for prenatal visits. If she has a high-risk pregnancy, she's in big trouble. If she's trying to get to deliver and has to get there in an emergency situation west of the river when she's ready to deliver, and then if she's having a premature birth, that's even more of a challenge. So we started, the March of Dimes, we started to look into this and do even more research to sort of identify maternity care deserts, and we're finalizing that report. It actually will be coming out next week. But what we're seeing is that there are millions and millions of women in this country who live in a county where there is no hospital that offers obstetric services, where there is no OBGYN, women that do not also have health insurance, women that are, when they choose to become pregnant, hopefully they have an ability to choose and make that choice, will then find themselves in a county, in a place where they have to travel, you know, maybe hours, and it may be impossible for them to access the kind of services they need. So when we're talking about systemic challenges with respect to not only healthy moms, but healthy babies, we have huge gaps in this system, and we know that those systems are everywhere in this country, and not just in rural areas, although that's a huge issue, in urban areas as well. And I think it's something we have to address by looking at the levels of care that need to be available, but also just the availability of care. It's one of the reasons why we've also been looking very deeply at how we expand the kinds of services where women might be able to access those services and have healthier pregnancies, be healthier before pregnancy, which is really a very important way in which to ensure that they are healthy as well as their babies. But looking at health clinics, at doulas, at midwives, we know that women of color are far more predisposed to wanting to access those kinds of services, but they're also not as available and need to be ramped up as well. So we need full-on solutions to this. This is not just a one-size-fits-all problem. There's no one single solution to it. We have to have a very comprehensive approach, but we actually do have documented evidence of huge gaps in the system that are affecting millions of women.
So we have, again, here in the city, we have a very low-hanging fruit. There's funding for a hospital, and we're talking now about a hospital that's not going to be built till 2023. So why is it taking us so long to build that hospital in an area that needs it desperately? So I think 2023 is 5 years from now. We build things in 18 months, 19, 2 years at most.
Arenas.
Yeah, arenas and all kinds of things. But and so that needs to be a priority. The money's there, the land is there, everything is ready to go. And you know, really, the old-fashioned midwife home visiting as a strategy. We now have telemedicine, care coordination are just places that we can come together with community health centers that actually are funded to do this work. And we should be working much more collaboratively with hospitals to make sure that hospitals are not creating things that are already in the community. We have 2 community health centers in Southeast, and it's taken all these years with the hospitals takeovers of the hospital that used to be there, or still there, and no collaboration between primary care and the tertiary care. So,
can I mention one other thing, which is the DC, this is a national conversation. I'm just going to use another DC example, though, since we're here. The DC Primary Care Association issued a fantastic report that actually talked to real women. You know, we, as experts in the field, we love to hear ourselves talk. It's actually good to go out and listen to real women talk about their own experiences. We actually learn and implement things that actually respond to those needs. I think this report was really telling because one of the things that it showed is that then the listening that they did were women who were covered by Medicaid, women that were pregnant, had a baby recently. And what it said was really important. I think one of the things that it talked about was the fact that the word of mouth that is shared among women in communities is as powerful a place to get information as any other place. So if you have a friend or another woman in your neighborhood or your community that went to a healthcare provider and got terrible service, felt disrespected, didn't feel listened to, didn't feel like the healthcare provider was empathetic, maybe something went wrong in her treatment, that word spreads like wildfire, and that is as powerful a place to find, you know, what the community feels about it. So even if there are providers and institutions and places, that is not, the bricks and mortar alone are not enough. Right. They have to be institutions and individuals who are responsive to the community, who listen to women. When women tell them what's going on with them, that they respond to those needs. In too many cases, we're finding, and again, irrespective of income and race. So while this is there are a lot of issues around poverty for sure, an educated black woman like myself can go into a place and be as unlistened to as any other woman as an African American woman. And so I think one of the things we have to be clear about is the fact that we are experiencing in too many places where women of color just simply do not get the same kind of treatment.
Oh, yeah. Mm-hmm.
And that has been well documented, and
Yep.
that's another thing that we have to address and be very clear and upfront about.
Yeah, absolutely. Or people just saying, you need to lose weight, or,
Yes.
something like seeing that as
Yes.
the solution. I'm going to turn to audience questions in a minute, so be thinking of your questions. But first, I want to dig in a little bit into the solutions to this. Can you guys talk about some of the more promising things you've seen? I heard about centering pregnancy. Maybe you guys could talk a little bit about those types of initiatives.
Yeah, so centering is one strategy, right? So it's not like the all solution, but being able to get women together in a group in the same trimester of pregnancy to talk and learn from each other. Where the midwife really does the minimal amount of work, but the work is really the conversations, the networking that happens between the women is very, very, very important. And we've taken that, and many of us have taken that and said, can we have those same conversations before people get pregnant? So when they have chronic diabetes, or pre-diabetes, when they have heart disease, and when they have any kind of chronic disease, to have that kind of conversation with women to learn from each other. You'd be interesting to know, some of the immigrant women are learning from the Afro-American women and vice versa, and learning about the systems and learning, you assume that you know what the system is because you lived and you were raised in this city for years and years and years and generations. The fact is that there are so many services that our community still does not know, and so we need a bank for those. But centering is one. The other one is around home visiting. Again, these are strategies. Home visiting is not for everyone, but it is for those women and families that are under so much stress that can't really make it to the other side of town to get the prenatal care. There is telemedicine. Telemedicine is another, and care coordination, making sure that we navigate people through the system. How many of you have tried to navigate the healthcare system when you have a chronic disease or when you're even just pregnant to try to, and you're high risk? So navigating that in building a community around them, like you said, of people that they can go to, not only in their neighborhood, but in the place where they work. The work, I just want to say to everybody here, work is a very, very special place for pregnant women. Not just, we've kind of gone the battle of making sure that people can breastfeed in their places of work, but also being able to be accessible and to be supportive of women that are pregnant. It's very, very important, and I'm still shocked of how many people, especially our low-resource individuals, who if they miss an appointment, or come to an appointment and miss a day of work, they are let go of their jobs.
Yeah.
And
yeah, I'd just like to pick up on one thing that we've all mentioned a couple times, but that is the power of telemedicine. And if we aren't careful as united sort of professions, telemedicine can once again be designed so that it's in the province of the wealthy. And it makes our lives very much more convenient. Telemedicine is something that the poorest of the poor around the world can adapt, and they can use it to just jump miles beyond where they would be. But it requires attention, it requires focus, and it requires money that is looking at their needs that can be addressed by this, and not just taking care of the needs of the better off.
Yeah. A few quick solutions.
Yeah.
There's legislation pending right now in Congress that would authorize maternal mortality review committees across all states. We do, CDC does a great job of collecting data on pregnancy-related deaths right now, but we don't have enough information to actually delve deeply into the actual causes of those deaths so that we can understand, collect better data, and design interventions at a local level so that we can actually reduce deaths. The other thing I would say is that in addition to supportive pregnancy, or centering pregnancy, group prenatal care, which we know is an evidence-based program which can reduce the risk of preterm birth by up to 40% in women of color, up to 30% for all women. We know that there are programs that are just not simply available to many women that can be scaled. The last thing I'll just say is that I think there is an important part of this conversation that does start with medical schools, and it's how we train our medical providers. And again, these are not the only participants in the healthcare system, but I do think we should be partnering with medical schools to make sure there is the right kind of training, empathetic training, and training to make sure not only that doctors, physicians recognize social determinants and understand the connections and community that can help alleviate some of those things, but even understand the different ways, different nuances of dealing with different patients across. The gentleman that talked before about the code switching and the different languages, I thought was really amazing, because I thought what he was really saying is we are learning how to relate and communicate with different audiences in ways that they feel heard and respected, and I thought that was a really great comment at the end of the previous section.
I would just say also that we talk a lot in this panel about the primary care and about community. We also want to make sure that there's some guidelines and protocols for hospitals, so that when women arrive, that the hospitals are ready for a hemorrhaging cart that there's nearby, that there's accessible blood transfusion if a woman needs it. Sometimes, and this is honest to God because I've been there in some of these hospitals, if depending on what kind of insurance you have is the way that people get treated. And so I think we all need to be held accountable with the whole healthcare system, because those few moments of not being able to get that blood on time and not having that card can mean life or death for a woman.
Yeah. Well, unfortunately, that's our time. But thank you guys so much for coming and digging into this important issue. And thank you all for being here. Thanks.
Thank you, Olga, and our panelists. And here to talk about communities leading the way, please welcome Erica Clark-Jones, Executive Director of Celebrate One, based in Columbus, Ohio. Chris Bradshaw, Executive Director of Dreaming Out Loud, based in Washington, D.C. And Ruth Ann Norton, President and CEO of the Green and Healthy Homes Initiative, based in Baltimore. And welcome back the Atlantic's Van Newkirk.
Clear it out for us, Chris.
Well, I'm back. And we're talking about communities leading the way. In light of some of our previous conversations and other panels before, I wanted to talk about how we can get these conversations at the community level that are developing in groups of people that are maybe at the cutting edge. How do we get capital P policymakers involved in that? Erica, I wanted to ask you first, in your capacity and career in community engagement and also in advising elected officials, how do we do that?
Thank you for the opportunity to be here today. So in Columbus, Ohio, I lead Celebrate One. We have a team of 72 community health workers. They are from 8 of our most disenfranchised neighborhoods around our county. And we utilize them not only to help moms and walk alongside moms and provide education and guidance over barriers related to social determinants, but then those health workers come back in and they download with us and with our policy committees and with our teams. Celebrate One is situated in Mayor Ginther's cabinet, and so what we learn, we share across the cabinet. So if we have neighborhood safety concerns or perception of safety, the director of safety is there, and there's some insights we can share. If there are housing concerns, which we have many, I think everybody does, affordable housing, housing for homeless pregnant women, all of those situations, we can bring that to a cabinet level. We then, quite frankly, leverage the mayor's interests to bring other partners to the table, county partners, our state representatives as well, to come up with a comprehensive solution.
Ruth Ann, it seems we're having more of a conversation now about lead poisoning than we maybe ever have. A lot of your work is in lead poisoning and lead mitigation. How do you use that energy in mobilizing different partners, different pieces of the community, and how has the conversation about lead mitigation changed?
Well, I think back to, we talked about this when you were in Baltimore. We were begun by 9 parents whose children were poisoned by lead so badly that they were in the intensive care unit at Johns Hopkins Hospital in 1986. And yet they lived across the street from what was and is one of the greatest health institutions in the country. they set out a vision that said we have to look at these twin tragedies that we're looking at today of deteriorated housing stock and ill health, and that we needed to find a way to break that. And I do think there continues to be this surprise over the course of history of what we've known about lead. Every time there's a new story, it's like, oh my God. And we've been dealing with this for 100 years. But what we have found is lead is a symptom of poor housing condition. It's a symptom of the decisions that we've made about how we will treat dollars. And it really does go back to the common sense that we're talking about here today. When we talk about going upstream, we're really talking about going into people's homes and into their communities. And so we've been able to show a 99% reduction in lead poisoning in Baltimore and have built a body of national work around healthy, safe, and energy efficient housing. But that 99% reduction in lead poisoning in Baltimore has yielded a $44.5 billion economic return to the state of Maryland. And I think the connection now is, how are we doing that reinvestment that actually goes to the benefit of generations who've lived with the toxic legacy? And we've taken the data and what we've learned to now make the case to Medicaid managed care, to our partners at United and Amerigroup, to say we can address asthma reduction, lead poisoning, those things that get kids healthy and ready to learn in the classroom, as cost savings, do the right thing, stabilize neighborhoods, give a better trajectory to children, and do the same thing for our seniors and care for housing as an integral part of healthcare. And that's what we're trying to do.
So you talked about these folks who are suffering from an imminently preventable condition across the street from a world-class healthcare center. Yeah. We are talking about communities, and it seems to me a lot of that conversation is, yes, it's about getting the policymakers involved, but it's also about getting these institutions that are geographically part of the community, that are economically part of the community, but don't necessarily see themselves as responsible for or engaged necessarily in the health of that community.
I mean,
right?
and anchor institutions go outside of healthcare, right? We are battling to get Hopkins to put community benefit dollars into the city. They're doing very good things. We have a project that we're going to take every child who's missing school for asthma in East Baltimore, go and assess their home and fix it because we know the healthcare return. But anchor institutions also go outside of that. It's the employers. So you're talking about Baltimore, it's Under Armour, it's the University of Maryland, it's Towson, it's Coppin, it's Morgan State. All of these anchor institutions have to be deeply engaged, not just studying what we talk about, but engaging and listening. Every single policy that we've ever made has come from a parent or a homeowner or a worker in the field saying, hey, you got to look bigger than lead. You got to know that people are sick, and you've got to look more holistically. If you follow those threads, we have every kind of community investment we make is a part of building equity in health.
Chris, with the Farm Bill coming, with all these different advocacy groups talking about SNAP, it does seem, in addition to the awareness about lead poisoning, we're also having a moment of talking about food justice. Can you explain to the room what your work is with food sovereignty, food justice, and how that relates back into this idea of community engagement?
Yeah, so our work is grounded in food. We have a 2-acre farm and food hub in Ward 7 here in the district. And for those who don't know, Ward 7 and Ward 8, I think we may have had some mention prior to, 95% African American, only 3 grocery stores for more than 160,000 people. Our work is really rooted on the ground, in the soil. So when we're talking about community-based solutions, we want to really get to that grassroots level, and we want to bring policymakers to that grassroots level down into the dirt, literally. So we don't want to go have conversations in the Wilson building. We want to bring people to the community. We're situated behind Kelly Miller Middle School, which has more than 400 students who predominantly receive free and reduced lunch, and Lincoln Heights, which is one of the largest public housing communities in the city. So we don't want you to be afraid to come and see where the rubber hits the road. We want to bring you into that space. And we're very fortunate on 2 levels. in relation to policy. First, I have the privilege of serving on the DC Food Policy Council, so you will see Food Policy Council members engaged on the ground in the spaces that we occupy. But we're also fortunate to be very near to Congress, so that we can have another level and layer of impact by just heading down the street and again saying, you know, come on out of that marble statue, those marble structures, and come on down to where we are. Community-based solutions are about bringing more voices to the table. Some of our partners have experienced the circumstances and situations that we're talking about in a more proximity than I have myself. In doing this work, I have to recognize the privilege that I hold and work to break down those barriers so more folks can be at the table.
Do you find that all these people in these marble buildings now, are they thinking differently about the issue of food? It seems at least the lobbying has changed. There are more nuanced conversations about that.
Yeah, I think people are thinking more about food, but it's up to us to change the narrative of what the story is. We want to use food as a community economic development driver. There's a lot of opportunity for folks to be getting their own food businesses, to be able to be trained for opportunity in a new food system, but that new food system has to take on a different vision. More community ownership, so that means that more folks are owning their own businesses, more support for cooperatives and other structures and systems that allow for people to democratically access capital and be able to generate a living for themselves and their families.
You know, there's something to be said for reaching across systems. So with our agency, which we're Collective Impact, we purposely go out and reach out to folks across other systems. We use community-based agencies also to help drive the conversation. When you have communities that are speaking up in different places, going to their legislators and lawmakers, it's like the chorus rising up and saying, you have to address, for example, the high number of infant deaths coming from one particular zip code. 4 times as high as it is in the nation. You have to address unstable housing and food insecurity. And so we feel we've used the technique where it's strength in numbers, but we're creating a very diverse coalition.
Ruth Ann, so much of this relies on community health workers, on people who have actual connections to the community, also being involved and sort of leading from within, right? How does that factor in? I know we talked about this before in Baltimore. How does it factor into your work, getting people to have that stake and to be helping other folks have that stake?
Well, I think it's critically important that the best results grow from the most local places. And I'm thinking, you know, I was listening to Steve Nelson earlier, and he remarked that we spend 20% of our healthcare dollars on social determinants and 80% on post-facto kind of healthcare. You know, we have an opportunity in community with so many leaders who actually know the common sense solutions that exist right in front of their own community to have a true economic development engine. If we reverse that ratio of investment, I think about environmental health inspectors can make $65,000 to $85,000 a year to look at housing, and these are permanent jobs with healthcare benefits that people who are in communities who are underemployed and unemployed can have that pathway and career so easily in contracting work, in the work you're doing around health, around food. I think there's leadership that has to come because people know their surroundings, they know what's impacting them, they know what the risks are in their communities. But there's also so much benefit and so much savings that we will get if we flip that investment. And for us, we're trying to solve for $150 billion of avoidable cost, $50 billion on asthma, $50 billion on lead, $50 billion on preventable injuries alone, not to get to the impact, not even to touch the impact of energy efficiency on health. Those are jobs, those are local jobs that can grow into companies that are owned by communities. And what we get from that is billions of dollars of taxpayer savings, more stable communities, and kids who get to the classroom, who are gonna graduate, who are gonna compete, who at 3rd grade level reading will have the 30 million word vocabulary versus the 3 million word vocabulary.
Chris, I've lived in D.C. for some time now, and it seems the challenge with a lot of programs in the city is the fact that so many people who live here today in Ward 7 will not live there in 2 or 3 years. And food justice is an issue tied up in that. Also healthcare services, also housing. All these things are they're both factors in predicting displacement and also are negatively affected by it. How do you deal with the fact that you are your work is treating an ill that is going to also negatively affect your work? How do you deal with that?
Yes, difficult to reconcile sometimes, but we have to be unafraid to speak truth to power and talk about the intentional construction that has built the systems that keep our communities under the boot, so to speak. Yeah, displacement is happening at a pace where I don't know what to do on any given day to stop it or to slow it. But we have to be real about why those policies and those decisions that are made continue to be made. We're heading into election season, and here in the district, you'll see all these LLCs pop up. ABC 123 LLC, 123 ABC LLC, $1,000 here, $1,000 there, $1,000 here, $1,000 there. Those are the systems why we need campaign finance reform. We need to have those conversations building power on the ground that can turn over those ANCs and those council members who are afraid to say no to those numerous LLCs. Those are the influencing factors that keep the engine going. For our nonprofit partners, we exist in a space where we have to balance those things, but we have to, at the end of the day, put community first and not our pocketbooks. It's a challenge, but it's something that has to happen.
If I can get in on that, it's very interesting. With our health workers, we build an infrastructure, essentially a pipeline to give communities a voice. And we have a particular community where residents are challenged by transportation, challenged by food access, medical care, and so forth, and easy access to employment. So we're building on the outskirts of our county, and there were lots of conversations about if we develop in a certain part of the area, will folks start moving out? Gentrification happen, folks moving in. Well, there was significant community dialogue. We had the right leaders at the table, and that includes our mayors and Department of Development and other key stakeholders. Hospitals were also in this space. And the community residents said, you're always giving tax incentives to bring new residents in. Give us a tax incentive to stay. How about that? And so just in the last 6 months, through the Rose Fellowship, Columbus did an inclusionary zoning new policy where they are now incentivizing folks who have lived there over 30 years to stay. How do we direct home repair and other things that would keep them in their house, give them a tax abatement as the property values rise so that they can remain in their homes? That stabilizes neighborhoods, right? A lot of these folks are connected to that ground, and we're building that infrastructure where they at least feel they have some level of empowerment, they have a voice, and they can stay right in their community, and we support that wholeheartedly.
I have a follow-up for you, but I do want to make sure everybody's thinking about their questions. I'll come back to you all in just a minute. Erica, bringing in a piece from the last panel I did, where we talked about the role of community leaders who are already plugged in, who are already fluent, especially in Black communities, lots of Black women who have the healthcare information of generations sort of downloaded already. How do we tap into those resources, and how do you build, you talked about building a pipeline, how do you make the formal structures work to accommodate and foster that?
So we leverage our position, frankly. Because we are in the mayor's office, we are a backbone agency, we know our role. We stay in our lane. Essentially, I just create pipelines for community leaders to come through and have a seat at the table with influencers that can change policy. And that has always been our mission. We do it for residents, we do it for hospital executives, we do it for community leaders, faith leaders, and quite frankly, Columbus has embraced this way of doing business. And that's the coalition that I speak of. It's a very powerful tool to be able to have folks stand shoulder to shoulder and say, this is why we should do this as a community. And quite frankly, we've made significant allies with those community mothers and fathers and grandmothers that don't feel like we're in competition. We're just trying to ease the path, quite frankly.
Can I jump a little bit on that? Because the community health needs assessment that nonprofit hospitals go through every 3 years, they ask people like us to be at that table. Yeah. And what really has to change here is to ask those grandmothers, ask the young people who are coming up, who are engaged, and really have a better dialogue of what is happening. But the idea of solutions that work over time, I've been doing it for 25 years, and it's still those solutions that you hear. That's the cross-sector partnership that actually bears real fruit, that we all want to draw from, but it has to be done in a way that is engaged. So I'm so excited about this incentive program you have in Columbus about getting people and turning the dollars to the people who are living this and helping to solve for the problems. But that's part of what I think has to happen.
Just as a last statement on that, if the community doesn't embrace it, it's not sustainable. And so we really see engaging members of the community to co-design solutions is the sustainability model. Because if they don't embrace it, we're just there temporarily.
All right, and with that, we'll have questions. One right here.
Thanks. Ryan Moser at Corporation for Supportive Housing. So first off, this may be my favorite discussion of the day, really fascinating. Second, as a question, so you talked a little bit about health infrastructure, about food infrastructure, about housing maintenance infrastructure. Can you put your brains towards what does that community health center growth lead to as far as a health delivery infrastructure in thinking about that 20%, and how should communities be included in thinking through the design of what that looks like and how to deliver it?
You want to start? Jump in on food first.
Yeah, so I mean, from the food perspective, I mean, if you're building out a hospital, that hospital is going to have institutional purchasing, right? So what does it look like to have community members have more ownership over the infrastructure, the physical infrastructure, say cold storage, refrigerated trucking, a farm that could actually produce or aggregate and supply that hospital with its food needs in a way that then creates jobs for folks that may have barriers to employment. So if you're building out these institutions in the community, how do you upskill the folks that are in that neighborhood to be able to access what employment may come or what entrepreneurial opportunities may come? So I think, community health benefit dollars have a role to play, foundations, and there's a role for government to play. We have to, again, acknowledge that government has played a role in developing and influencing the circumstances that keep people oppressed, and that has to have a role in uplifting people as well.
I think on the housing maintenance, I know you're behind the thing, I can't see you, but Brian. But I think if we've taken an approach of aligning the resources that exist for housing and trying to maximize that delivery to lower the impact on how families experience getting their houses fixed, right? We looked at our system and said for a family to go after the 5 or 6 grants that they need to get their houses fixed, which will improve their health, they would miss 23 days of work. And if they don't do that, they will have their kid in the hospital for 3 and 4 weeks a year for asthma. And so we had to kind of solve for that and streamline that, and then say to Medicaid managed care especially, so if you know that what we're going to do is do work that will improve the rates of asthma or lower the rates of asthma, reduce emergency visits and hospitalizations, and have big economic outcomes, managed care has to be a part of that alignment. And I think following that outcomes-based alignment has been critical.
Erica, wanted to give
you the
closing word.
The only thing I jump in on is around community health workers, and I think I've heard this talked about in a couple earlier sessions. Integrating that health worker into a care model with hospitals and clinics is real. That we have a real opportunity there. If we're hiring health workers from neighborhoods where they have the relationships, they understand what's happening on the ground, being able to incorporate their voice and them as a part of the care team, the integrated care team, seems like a solid pathway going forward.
Well, Baltimore, D.C., Columbus, looks like we got some good folks working there.
Thank you.
Well, thank you all for coming, and thank you all for being
here.
Thank you.
I'm headed to...
Thank you, Chris, Ruth Ann, Erica. And thank you, Van. And we so appreciate everyone here in this room joining us. And thanks again to United Healthcare for making this morning possible. And wanted to let everyone know that our Atlantic Festival is officially kicking off today, and hope some of you can join us at the Harmon Theater. Our main stage programming is beginning at 2 o'clock with former Secretary of State Hillary Clinton in conversation with Atlantic editor Jeff Goldberg. We still have tickets available for purchase, so mention that you were at the forum. Head over to the AT&T Ideas headquarters at Rosa Mexicana if you're interested in attending. Thank you. Take care.